That was excellent. Every talk was excellent. We've got about 8 or so minutes for a panel discussion. We'll take questions from the audience as well. But I have a question for the panel. We saw a whole bunch of beautiful repairs, some very complex, some moderately complex. You'll often see somebody who's got balanced bileaflet prolapse, no ruptured cords, a central jet. You walk into the OR and the anesthesiologist says, a ring alone. And I virtually never do that. There are papers about it, ring alone for Barlow's. Virtually never, I think. But correct me if I'm wrong. Let's run down the...
You're absolutely right.
I'm so glad.
I mean, Pat, what do you think?
I agree. If you look at those papers, and they'll describe the results as being very good, look at the failure rate. And in general, we really should be looking not just at reoperations, because for instance, at Northwestern, we call them reinterventions. Half of the patients that needed a procedure, it was transcatheter. Maybe they got TEER, valve in a ring. So we should be looking at reintervention, plus we should be looking at the number of patients with recurrent 3 to 4 plus MR. And so they had a pretty good amount. So I do a resection of the posterior leaflet, and Mark, from your paper years ago when we were at Cleveland, if there is not very much anterior leaflet override, it's going to hit against the posterior leaflet, and you don't need to treat that.
I would not do a ring only, but if the purpose is to generate some controversy and some audience participation, one of the authors of one of those papers, Mike Borger, is in the audience, I think, and he could comment.
Yeah, I completely agree. Usually I would analyze both leaflets, and usually some of the posterior part of the posterior leaflets would be a bit too tall and resect some of it. And once I've done that, I would look at the symmetry with the anterior leaflets and maybe add some cords on the anterior leaflets. So it's quite rare to use an annulus alone. What about you, Mike?
Let's please take questions from everyone who's here for this fabulous symposium. Oh, we got Michael Borger.
Yeah, Joe, thanks for putting me on the spot here. Actually, I didn't co-author that paper. We had a different technique with a Alfieri stitch, which we abandoned a long time ago. But the isolated ring, I think the person, I don't know if he's here, Ehud Ranani? Is he here? Okay. Okay, too bad. Ehud has the biggest, from Tel Aviv, who was also a fellow here at TGH under Tirone, has the biggest experience with that. I think about 40 patients now. It has to be a very, very the right group of patients. There can't be any flail, obviously. It has to be a very symmetric prolapse. It can't be this sort of asymmetric billowing that you sometimes see for these Barlows. The whole thing basically has to be symmetrically prolapsing, and Patrick Perrier has also published on this. We've done it a few times in Leipzig. It's pretty remarkable. It does really give a very good result, but the long-term results, at least in our hands, we don't know yet. But Ehud has some good long-term results.
Yeah, you know, this is, I'm just going to say, this is a complex field. It's not a simple field. We're always trying to simplify things for the surgeon. I'm interested in simplifying things for the patient, which is to keep them from coming back. And I like what Tirone taught us, again, reminded us of form and function. Yeah, the whole concept of valve reconstruction, and this is really Carpentier's genius, was to try and restore normal anatomy. And this is where I'll go back and I'll say, and Pat and I were whispering, Morale was texting us, you know, this is a hot mic, you guys have to behave. And I said, don't put us beside each other. But I was going to tell you guys, yeah, but I'm going to tell you guys something that we were both commenting the same thing. We both do a lot of reoperations from around the United States. The number one, by a mile, not even close second place, reason we do reoperations is no resection, Gore-Tex-only valve repair, by far. And the reason that is because you are leaving abnormal anatomy behind. It is hard to line up. The ventricles can remodel. Generally, they represent with prolapse. And for the life of me, Michael, I understand you can do it, but why would you do it? That patient you showed, this little simple triangular, little simple prolapse, a little 5-minute triangular resection and then a Gore-Tex, why wouldn't you do it? Like, what would be the reason not to do it? And by the way, this is just, for those of you that have never been to the micro conclave, this is what we do. We actually really have fun. We argue and we go way over every session, so we can really do this kind of thing. But why wouldn't you do a simple triangular resection?
So I think that you can do a simple triangular section, but also, you know, I think fighting this battle over neocords versus resection, I think they both can achieve good results. While you guys, you know, have a big experience with neocord failures, you know, it's likely that we're looking at one end of the spectrum. And I would argue that it's not a neocord failure, it's probably a failure of the repair strategy, that they didn't achieve following all the principles of a, you know, repair that we would expect. And, you know, in many cases, what happens is maybe the coaptation was left too anterior, the neocords were left too long. People oftentimes will say, well, you know, there's remodeling. I'm not sure that that actually exists. You know, many times it's probably either the neocord length was wrong in the first place, or, you know, I understand you oftentimes present the neocord rupture. I've never seen it in my experience, but, you know, I can imagine it happening, and, you know, people use CV5, whereas, you know, I generally will use CV4.
I've never seen I don't think I've ever seen a neocord rupture. It's the elongation. They're in general, they all represent with new prolapse. That's really the
Well,
main
let's-
But I think it's incomplete correction at the first operation.
Okay, let's commend Maral for generating a topic and setup of speakers to create this controversy, and let's go to Tyrone David
Tyrone.
for his opinion on this.
You know, at different ages in our lives, different parts of the body are more important than others. Hemorrhoid is very important, believe it or not. But I have never done to my patient what I don't want done to me. No, honestly, or I try not to. All of you use Gore-Tex, have all those knots in the atrial side of the leaflet. Don't you worry about what's going to happen to those knots, bulky knots that Gore-Tex live? My very first description of Gore-Tex in '85, starting in fibrous portion, came to prolapsing segment. When I adjust the length, I turned the Gore-Tex to the ventricular side, and I tied the knot only ventricular side, high pressure area. Some of your videos has about 10 knots there. I don't want that 10 knots. That's what the blood goes through before it goes to my brain. I mean, and the brain is the most important part of my body now, so I don't want this done to me.
So I want to make a comment about neocords. So the conceptual problem I have with neocords is the variability in it. So here's the math. So your normal P2 is 12 millimeters. Average P2 in degenerative MR is 20 millimeters. So to get a good amount of coaptation, you have to pull that posterior leaflet down into the ventricle. How much? And that's where the variability comes in, and it depends on who the surgeon is. If you're Tyrone, you're going to be able to look at it and you would get it right, but not everyone is. And so that's why we do the re-ops, is that some people are like, oh, let's make sure that the cords close at the level of the annulus, and therefore they're going to leave all that big bulky tissue, but you know, other people pull it down. You know, you could pull it too far down and you might get restrictive motion. I mean, it's a judgment. Like, I want to take the judgment out of the operation so that you don't have that kind of variability.
Patrick, I don't believe when you put a Gore-Tex, you're going to make it too short or too long. You should make it right. And the concept that, well, I do the
No
Gore-Tex
argument.
perfect in the operate room, now the ventricle is going to shrink, and the Gore-Tex can become too long. How come it doesn't happen to the other chorda tendina, to the normal chorda tendina? So put the Gore-Tex in the length of the chorda tendon should be. I mean, it should not be too long or too short. I mean, it's not simple.
But if somebody, even a moderate mitral surgeon, maybe does 10 to 20 a year,
No, that's not
are
enough.
they going to be able to look at that and say, this is exactly the
No,
right
you're
amount?
right.
Joe, you do all those studies at Stanford in animals. You have to be pretty damn
I
precise
think
to
repetition
get
makes
this right.
perfect, yeah.
But whether you pull down the leaflet by resection or by neocords, you're blaming the neocords. It's the failure of pulling down the leaflet far enough into the ventricle.
Well, it's
That's
pulling
the
it
failure
down
of the
too
problem.
much or too little. It's a judgment. All I need to do is look at what's normal cord on the left and
But I
right.
think what's been sold, Michael, is this idea that somehow it's easier the new generation, the old dinosaurs doing resection, the new generation doing all the loops. You saw the pictures he picked, right? And it's all baloney. And just what we're saying is, whatever you do, I don't care if you want to do all non-resection. I highly recommend you don't. But if you want to try that, just realize it's a very nuanced repair that has lots of ways that you can screw it up. It's not just straightforward, put a couple of loops in, and all goes away. It's all matters, and that's why I said you can't dumb down the field. Whichever one of these things you do, I highly recommend you blend approaches, but it is all going to require a lot of thought, or you can really, hurt the patient and they come back.
You've been very patient. One last comment or question.
Thank you very much for being here in this quite important symposium on our friend Tirone David, which represents the quality of we surgeons from Brazil. That's what I mean. I have a very important operative technique, and before I have to say a lot of this knowledge that you have taught to us. But I have an important operative technique, which is most of all of us, we can make a very good mitral valvuloplasty or things like that. But I have a curiosity, because my wife has mitral prolapse. When we correct on a valvuloplasty, angina and pain which patients with prolapse have diminish or go out, I don't need to know about sudden death. The pain of prolapse diminish or disappear when we make the correction of the prolapse for a valvuloplasty?
I think. I think that was a definitive answer. Unfortunately, we need to move on to the next session, but thank you to this excellent panel. And if we could ask the